So good
Welcome.
evening, everyone, and I thank you for joining this invited lecture series. So far, we had a very good response from our members to this series. And at the outset, I wish to have comments of our president, Dr. H.C. Taneja. Dr. H.C. Taneja, please.
Thank you, Vipin, and good evening, everyone. So today we are having another topic which is very important for the postgraduates and for the practitioners also. That is a juvenile nasopharyngeal angiofibroma. So today we are going to have one presentation by Dr. Hitesh Verma and one panel discussion, which is moderated by Dr. Ravi Meher. So I hand over now to Chairperson, Professor Aditya Bhargav and Professor Khaja Nasruddin. Please, sir.
Okay, thank you very much, Dr. Taneja, Dr. Ravi, and Dr. Vipin for giving me this opportunity to chair the session. Juvenile, as everybody knows, how important, how tedious or simple can be a JNPA rather, not JPNA, JNPA. So it's a very topic well chosen, and I believe Dr. Hitesh, who is going to be in some time, or maybe he is already an authority on JNPA, will enlighten us with all the basics and fundamentals, and then the techniques of removal, and we will gain in knowledge. At the very onset, I may say that this is a very, very good forum, and people like Dr. Vipin and Dr. Ravi Meher, they are doing yeoman work for the AOI. So I congratulate them. And now I hand over to Dr. Vipin Arora for further proceedings. Dr. Khaja, if he wants to say anything, sorry, I interrupted in between. If he wants to say anything, he can pitch in. And later on, Dr. Vipin can take over and we'll start the proceedings so that we can finish in time.
Thank you, sir. And Dr. Khaja is here. Dr. Khaja Nasruddin has joined.
I don't see him.
Okay. So I'll just introduce the speaker, Dr. Hitesh Verma. He's a dear friend of mine and a treasurer of AOI Delhi and a long-time colleague of mine, both in Chandigarh as well as in Delhi. And he's additional professor of ENT and head and neck surgery at All India Institute of Medical Sciences, New Delhi. So that says it all. So I request Dr. Hitesh Verma to begin his presentation.
Thank you very much, sir, for introducing me. So my topic is diagnostic and management of JNA. So diagnosis start from the history, and the recurrent bleeding and persistent nasal obstruction in young adolescent male itself raise the eyebrows. It may be juvenile nasopharyngeal angiofibroma, and bleeding is moderate to severe in amount. Patient would require nasal packing, blood transfusion. That itself suggests that bleeding is very high. So it may be suggestive of juvenile nasopharyngeal angiofibroma. Next comes a nasal endoscopy. As a disease is found primarily in young children, either in first decade or second decade of life. So if patient allows, if patients allow nasal endoscopy, then it is a very good tool to pinpoint the diagnosis. So here in this upper picture, we can see the normal nasopharynx. And these are the three different kind of pictures of nasopharyngeal angiofibroma. This is reddish, we can say reddish pink. Here the reddishness is much less. This is a white, relatively whiter. So single globular mass in the posterior half of posterior part of the nasal cavity and in the nasopharynx in young adolescent male is suggestive of primarily nasopharyngeal angiofibroma. Next, once the suspiciousness generate with the help of history and examination, next investigation comes as radiology. So either we can do CT as first investigation or CT angiography. So CT is helpful in creating the diagnosis because nasopharyngeal angiofibroma arises from the region of sphenopalatine foramen. So typical site of origin, typical disease spread. If this mass extended superiorly, it can involve a sphenoid sinus. If it extends laterally, can involve the it extends to pterygomaxillary fossa, then infratemporal fossa, and from the infratemporal fossa into the cheek. So typical site of origin and typical pattern of disease spread helpful in creating the diagnosis. And radiology is also helpful in staging. So we can plan the treatment according to the stage, because in early stage endoscopic approach is good enough. As the stages advances, we can move to open approaches also. And if CT angiography is done at first stage, vascularity can be pinpoint, so that we can plan surgery in which way we want to do. If good vascularity comes from intracranial circulation, then that I will discuss later on. So Redkowski staging system is the most commonly used staging system. And stage 1A when JNA is limited to the nasal cavity and nasopharynx. Stage 1B is extension into the one or more paranasal sinuses. And stage 2A is minimum extension into the parapharyngeal space. Then stage 2B is pterygomaxillary pterygopalatine fossa, and 2B is when pterygopalatine fossa is fully occupied with or without erosion of the orbital plate. And stage 2C when there is extension into the infratemporal fossa with or without cheek extension, or maybe posterior to the pterygoid plate. Stage 3A is a skull base erosion with minimum intracranial extension, and stage 3B is gross extension plus minus cavernous sinus involvement. So there are a number of staging system available on literature, and this staging system is most commonly used staging system. As I told you, in angiography, it is helpful in locating the mapping the feeders for the angiofibroma. So either angiofibroma generally receives circulation from the external carotid system. At the site of origin is in the posterior part of the nasal cavity and nasopharynx. So it initially take bleeders from feeders from sphenopalatine branches. As the tumor extends in its dimension, it can involve ascending pharyngeal artery, internal maxillary artery, sometimes contralateral circulation, sometimes vertebral artery, or can involve a intracranial circulation also. Next comes the MRI. So in MRI, what we can see, it's hypo-intense on T1 and intermediate to hyper-intense on T2. But when we administer contrast, we can see bag of worm appearance, which is because of high vascularity. So indication of MRI is reserved in the condition like if we have diagnosis, the doubtful diagnosis, in that case, we can go with MRI because it has better soft tissue characterization. And when there is an invasion into the intracranial cavity, so relationship with the cavernous sinus, dura, internal carotid artery, that we can map. And to detect the residual lesion in the post-operative period, because MRI is not associated with radiation exposure, and to assess the response to the medical management, which is either radiotherapy or some hormonal therapy. And then comes the DSN embolization. So in technique, it is generally done by transfemoral route, and a catheter is passed via the common carotid into the external carotid system, and once by digital subtraction, the surrounding structure was subsidized, and then we can map the extent of the tumor and the feeder and the blood supply, so that we can embolize that feeder. So advantages of embolization can reduce the vascularity of the tumor, which will helpful in subsequent surgical excision of the tumor. And it is generally done, surgery should be done within 24 to 48 hours. In our experience, surgery done on same day, it's less risk of peritumoral edema, as This is a disadvantage mentioned in the literature. As the duration of interval between the embolization and subsequent surgery extends, then the chances of peritumoral edema is more. And literature suggests there may be accidental spillage of these embolus material into the internal carotid system, which can lead to blindness and ischemic stroke. But I come across this article on laryngoscope, which is published in 2021-20, and it suggests they done selective embolization of internal carotid feeder like median artery. In few cases, not in all cases. Limitation was the angle of the branches comes from the internal carotid artery. So they found there is no complication was observed after the procedure, and there is no significant difference in terms of intraoperative bleeding and residual disease. But this is the only article and limited case report. So large study can be done on this effect. So biopsy, when should we do biopsy? As a history itself is suggestive of it may be JNA, and then subsequent examination, single globular pinkish reddish mass in the nasopharynx or posterior part of the nasal cavity, and radiology shows typical extent of the disease. So biopsy is not required to confirm the diagnosis of JNA. So when biopsy is indicated, when there is a diagnosis is doubtful, like here we can say these are the atypical presentation, even though both cases came as juvenile nasopharyngeal angiopharma, but presentation is quite atypical. Here we can see. And in another patient on similar age group, when nasal endoscopy was done, history was same, recurrent bleeding, and patient would require packing. But endoscopy shows there is a multiple polypoidal mass in the posterior part of the nasal cavity. So its picture is different. Like this is a case of rhinosporidiosis, where the mass is seen in the posterior part of the nasal cavity, but picture is different. In such cases, biopsy can be done. So treatment options are surgery, radiotherapy, and hormonal therapy. As the tumor is benign, slow progressive, surgery is a primary treatment modality. So surgery can be endoscopic, simple endoscopic, or maybe extended endoscopic procedure, and can be open either by lateral anatomy, Weber-Ferguson, maxillary swing, mid-facial degloving, and pre-auricular subtemporal approach. So literature suggests endoscopic approach can be done till the stage of 3A. But this in our experience, blood volume should also be considered for surgical option, because if child present with advanced stage with limited blood volume, for example, if BMI is very less, in such cases, we cannot handle too much blood loss. In such cases, open surgery is much better than endoscopic surgery. So endoscopic surgery need specialized equipments like high definition monitor, endoscopes, different kind of endoscopes, cameras, and to control the bleeding, we require like coagulator, drills. This is the specialized bipolar that can be used to control the bleeder, and the clip applicator and the flow seal to control the bleeding. So how to reduce the bleeding in both endoscopic and open cases? Pre-operative embolization. And in early stage embolization, use of embolization is doubtful because few studies shows they can perform the surgery without embolization, and few prefer embolization. So it can be surgeon specific and surgeon's choice. And I'm doing one of the study where I'm comparing the effect of embolization in early stage by doing RCT in up to stage 2C. So result may come maybe in 2 years or so. And other is a reverse Stedlenberg position, proper decongestion during the surgery, hypotensive anesthesia, and peritumoral vascular control before handling the tumor, and specialized instrument, which I already told you, cautery or coagulation. So this is one of the study from AIMS, and I was part of that study where we compare the plasma ablation, which is a coagulation technique, where we compare the endoscopic excision, where compare with the traditional technique with the latest technology. So we took out data from 2 year backward and 2 year subsequent period. So here we could find in group A, which is where the surgery was done with plasma ablation. So mean blood loss was 583, but where surgery was done by traditional method, mean blood loss was 1231 ml. So it was found significant, and it was found significant in term of excision of tumor and duration of surgery also. So this is one of the video where the tumor is it was found in 14-year male patient, and patient was presented with the history of same nasal obstruction, snoring, mouth breathing. And this is a picture. We can see is a globular mass, relatively whitish in the posterior part of the nasal cavity. Here we can see mass is confined to the posterior part of the nasal cavity, nasopharynx, and there is a limited extension into the sphenopalatine. We hardly see any extension into the sphenopalatine foramen. So it's so in such cases, not much lateral access is required because tributaries from sphenopalatine foramen may be the primary feeder of this case. So this is MRI scan, which also shows similar stage. So with the diagnosis of juvenile nasopharyngeal angiofibroma, stage 1B, as it has limited extension into the sphenoid sinus, patient underwent embolization because it was part of the study, part of the thesis that was embolization was done. But in another case, it can be managed without the embolization also. So first step is proper decongestion. Then after the wide removal of the uncinate process, wide maxillotomy, and anterior and posterior ethmoidectomy. Then the creation of space above the tumor by removing the lower half of the middle turbinate. And here is I'm using the cobblator, and this is a sphenoid sinus. So tumor was separated from the anterior lip of the sphenoid sinus, and this is a maxillary sinus of left side. The mucosa was elevated from the maxillary sinus, and maxillary sinus posterior wall comes in anterior relationship of the pterygomaxillary fossa. So after the initial widening with this widening of this pterygopalatine fossa, then I use a cobblator, and the feeder was generally very small at early stage, so that can be managed with the cobblator also. Otherwise, bipolar cautery can be done. So now the tumor is separated from the lateral attachment, and small extension was in the sphenoid sinus. That's why lower lip was removed subsequently. Here, the Carrison Ronger is used to remove the low floor of the sphenoid sinus. And then the tumor was pushed into the nasal cavity. And to control the breeder, then the base was found irregular, and as we know, cancellous invasion into the cancellous bone can lead to residual disease. So drilling was done from the site of attachment, and Surgicel was placed to control the bleeding. And as we could not find any bleeding in post-op cavity, so Merocil was kept, and it was used to support the flap also from the nasopharynx as the tumor grows under the periosteum. So in that case, mucosa can be preserved, and it's a benign tumor, so no infiltration into the mucosa can be seen. This is the final specimen. Next come the extension. Generally, nasopharyngeal angiofibroma can extend superiorly into the sphenoid sinus, which can be managed directly through the head-on approach. And lateral extension requires spatial instruments and like angled endoscope, angled suction, angled cautery, and all that to reach the infratemporal fossa. Either we can remove the here in this picture, this is a pyriform aperture. And this is the anterior wall of the maxillary sinus, and this is the lateral part of the nasal cavity. So here the osteotomies were given to the maxillary anterior wall of the maxillary sinus, so we can see entire maxillary sinus. This is known as endoscopic Denker's approach. So this can be done to reach up to the lateral limit to reach the infratemporal fossa, or we can remove posterior part of the bone of the septum, which is a vomer, and we can use angles to instruments. And this is for example, this is the right side of the nasal cavity, and this is a cartilaginous part of nasal septum, and angle suction is used to reach up to the lateral limit of the maxillary sinus and to the infratemporal fossa. In another approach, we can create window within the anterior wall of the maxillary sinus by sublabial approach, and two routes can be used. And another route is when tumor is very bulky, lateral to the maxillary sinus comes the upper gingiobuccal sulcus. So from upper gingiobuccal sulcus, we can reach up to into the infratemporal fossa. So this is one of the video where the posterior sublabial approach was used. Here we can see this is a stage 2C, which was bulky. But why it's so bulky, the gross infratemporal fossa extension and some amount of extension we can see up to the cheek, it is extending. So like steps which I shown earlier, initially superior space is created above the tumor, then comes a and the tumor, this mass lesion is separated from the sphenoid anterior lip, and majority of the cases, tumor generally take attachment from the septum. So that should be removed with the healthy mucosa surrounding, because if we are dealing directly over the tumor, in such cases, bleeding can happen. So now this is a sphenoid sinus, and it is being separated from its anterior surface. And this is the floor of the sphenoid sinus. And now attachment from the septum and roof of the nasopharynx is separated here. And now this tunnel is, this is the inferior turbinate. So in this case, as the tumor was very bulky, entire inferior turbinate was used with the help of cobblator. All mucosa was removed and osteotomies were made as I shown in the picture. And this is a maxillary sinus, and this is an extension of tumor into the pterygopalatine fossa and into the sphenoid sinus. So as the tumor was very bulky, it was split from at the region of the sphenopalatine foramen, because it is the narrowest part. So after the initial widening, I found tumor was very bulky, so it was removed in two pieces. So it is separation was as it is non-infiltrative mass, easy separation can be occur from the posterior part of the maxillary sinus. And now we can see tumor in toto. So next, this is a posterior sublabial approach. Incision was made into the upper GBS. As a finger was inserted from that incision and to push the tumor medially. So it was very bulky. Then bipolar cautery was used initially to. This is a finger which is coming from the upper GBS into the infratemporal fossa just to push the tumor medially. But tumor was very bulky, so it was separated from at the region of the sphenopalatine foramen, and first specimen was removed from the nasal cavity. And then this is the first specimen. It is coming out through the oral cavity, as it was very bulky and difficult to take out from the nostril. Then comes this is the second part of the tumor. And these are the clips which are applied over the branches of the sphenopalatine and the maxillary artery. And this is the second part of the specimen. This is after the removal, and this is a Vidian canal region. So Vidian canal extension was noted in the DSA scan. So it was drilled. And here we can see the posterior wall of the sphenoid sinus. So Vidian artery is a direct extension from the internal carotid system. So it can be used as a landmark. If we are going more and more posterior, we may injure the internal carotid artery. So in that case, surgeon should be cautious. And after the hemostasis, there is hardly any bleeding. So again, Merocil was placed. And this is a surgiform just to, as a raw area is very much in the infratemporal fossa. So just to pack that area, this is a surgiform was used, and then the Merocil was kept into the nasal cavity. And this is another where it was done without the embolization. Extension was, stage was 2C. Here we can see it is extending into the infratemporal fossa. This is a part of my new study, so embolization was not done in this case. So like I told earlier, proper decongestion, then creation of the space superiorly, then creation of the space. This is a removal of the middle turbinate. Superior attachment was separated, then the lateral attachment was also separated because it comes in between during the surgery. So it was cut at two sides so that we can have good view above the tumor. And then cobblator was used to burn the mucosa, and then the osteotomies were made. And this is a septal attachment which was separated from the septum and from the anterior part of the sphenoid sinus. So if Vidian canal extension is there, sometimes it may be difficult when the tumor is advanced stage like 2C. So in such cases, splitting of tumor is a good option because it allows easy access to the Vidian canal. So here is a bipolar cautery was used to separate the two parts. And the first part was removed, and then so first part is removed here, and then the Vidian canal extension can be easily assessed. So this is a Vidian canal extension, which we can see here, and it was lifted, and then the cautery is applied directly. As the tumor is bulky, it may be difficult when the tumor is not divided. In such cases, this management of this extension may be difficult in endoscopic approach. So now the tumor is removed from the Vidian canal extension, and this is a Vidian artery which is cauterized with the bipolar cautery. Now cobblator is used to cut that attachment, and then the posterior separation is done in this case. It was not that bulky, so easy pulling to the medial side allow access in the lateral part. So multiple clips were applied. Here we can see clips were applied to the branches. Here we can see bleeder from the sphenopalatine artery. So the clips were applied here. And then the tumor is separated from the surrounding structures. Now this is after the removal of the tumor. And this is a Vidian canal extension, we can see. There's a widening of the Vidian canal. even though drilling was done over the cancellous bone where it was found irregular. Here we can see healthy cancellous bone, but it was irregular in that part that was drilled, and then the surgicel and merocell was placed. So tumor can be removed piecemeal or can be removed in toto, but a removal should be complete. Like here we can see in the radiology, removal should be complete. So surgeon first define the limit of the extension of the tumor. So both are viable option, and multiple articles are on it. It should be removed piecemeal or completely. So advantages of endoscopic surgery is a cosmetic. It has better result in early stage, and this is a meta-analysis. The use of endoscopic approach to treat the JNA has significant lower recurrence rate when compared to the open approach. This was a conclusion of the article. But this limitation of the endoscopic approach is a learning curve, and it needs a specialized instrument to control the bleeding. High-end endoscopes and clip applicator, cobbler, specialized bipolar cautery. Few another approaches is a transpalatal approach is obsolete now because it was primarily proposed for early stage like 1A, only preferably for 1A lesion, and 1A is easily manageable with endoscopic approach. But here are the few incision which is proposed in the literature to handle the diseases within the nasopharynx. So either Y shape or L shape, or this is a O1 incision, like in this picture, complete O1 incision, and periosteum is lifted from the hard palate, and then the posterior part of hard palate is removed to expose the posterior part of the nasal cavity and nasopharynx, and then surgery can be done. Next come the extended maxillotomy approach. So this can be, as I told earlier, this can be combined with endoscopic approach for lateral extension, where the wide window is created in the anterior wall of the maxillary sinus, and the tumor can be removed from both approaches. When the lateral wall, lateral wall of the nasal cavity is removed in this approach, then it is known as Denker's approach. So entire tumor can be handled through this approach only when the entire nasal, when the lateral wall of the nasal cavity is removed along with the wide maxillotomy. Then comes a midfacial degloving. In midfacial degloving, this is a wide sublabial incision, and the cartilaginous part of nasal septum is separated from this pyriform aperture. This is a pyriform aperture, and then subsequently bones were removed according to the need of the surgery. And this is one of the photograph where the cartilaginous part of septum is elevated from the maxillary anterior wall and the nasal cavity, and this is a wide window which can be done. But disadvantage of this approach is primarily vestibular stenosis. And this is a transmaxillary approach, and ENT surgeons generally less familiar with this approach, but this is a leaf-out one osteotomy, which is along the floor of the nasal cavity and the maxillary sinus. So when this is a fracture line, and when the upper arch is separated inferiorly, we can have good view into the posterior part, of the maxillary sinus and into the infratemporal fossa. So when disease extend much laterally, there's a bulky lesion, and when the tumor volume is less. In such cases, and when tumor is confined anterior to the carotid artery, when it's primarily anterior to the carotid artery and bulky lesion. In such cases, we are doing maxillary swing approach. So this is one of the clinical photograph where the Weber-Ferguson lip splitting incision was made. And these are the clips which are applied at different osteotomy size. It is almost similar to the, like we are doing maxillectomy, but skin over the anterior face of the maxillary bone is kept attached over the maxilla for the future blood supply. Otherwise, it will lead to osteomyelitis of the maxillary bone. So this is one of the video. It was performed by Professor Alok Thakkar, advanced JNA. This is a lip splitting. Initially, the lip was split over the maxillary bone, and this is a maxillary bone, and here the Weber bone. Now it's being separated from the orbit. This is subciliary incision. Orbital flat was lifted, and this is the anterior wall of the maxillary. And now orbital tissue is lifted from the maxillary orbital plate of the maxillary bone. And once all the separation is done, here this is a frontal process of maxilla. And this is a oven incision. This is a picture which I told earlier. This is a Owen's incision. This is a periosteal incision. Next, the osteotomy is made along the midline. So the both incisions are different place. So subsequently, when the wound adhesions occur, the chances of fistula formation is less. Now the mini plates are placed for future approximation. So generally we place 3-hole plate over the frontal process of maxilla, 5-hole plate above the teeth, and 4-hole plate at the level of zygoma. So once these sites are demarcated, then osteotomies are made. With the saw. And here the anterior skin over the anterior face is kept attached over the anterior wall of the maxilla. So it will supply the maxillary bone after the surgical closure. So this is another osteotomy, third bony cut. Now the maxilla is separated laterally, swinged out laterally, and we can see this is a tumor. So entire exposure of the tumor can be done, and it is a good view which provides access to the maxillary artery. So we can say it's a very bulky lesion, and here is a maxillary artery which was controlled. So whenever embolization is not done, lateral to medial approach is better, because anyhow a lateral to medial approach is much better because most of the vascularity come from the lateral aspect. Ascending pharyngeal artery comes in the nasopharynx and posterior aspect. So primarily tumor receive blood supply from the lateral aspect. So lateral to medial approach is much better than tumor is separated from other parts. Once it got separated from all the parts, it can be delivered easily. So this is a separation. An open approach allow access to all the dimensions of the tumor. So this is after the removal of the tumor. Cancellous bone was drilled where it was found irregular because of the attachment with the tumor. So drilling was done at the level of pterygoid base. So after the packing, this is a conventional pack which was kept into the operated cavity. Then the maxilla is placed back and fixed with the mini plates. So these are the mini plates. So when lateral approach, when they are indicated when the tumor volume is very high, gross skull base involvement, when tumor is lateral or posterior to the internal carotid artery, and when there is significant residue even after embolization, maybe 40 to 50% residue is there. In such cases, lateral approach is much better. So this is a subtemporal pre-auricular approach. And this is after the elevation of the flap. We can see this is a zygomatic arch, this is a lateral wall of the orbit, and this is a temporal fossa, and this is a cranial cavity. So when we remove the osteotomies are made over the ramus of the mandible, either completely or partly over the coronoid process to access the infratemporal fossa. An internal maxillary artery comes deep to the posterior border of the mandible that can be handled easily. And this is a craniotomy. As a tumor is extending posterior and lateral to the tumor was extending posterior and lateral to the carotid artery, then craniotomies are made. And this is a zygomatico orbito temporal craniotomy. This is a orbital, this is a cranial cavity, and this is the lateral limit of the orbit. So here we can see the tumor after the creation of this craniotomy, and then with the retraction, tumor is retraction over the cranial cavity, tumor is separated from the surrounding structure of the carotid artery, and then it was delivered in toto. So this is after that temporalis muscle is placed back. Mini plates are used to reposit the cranial bone, and this is after the closure. So risk factor for residuals are large volume lesion on the extension of tumor into the median canal. So surgical management should take in particular care for the pterygoid canal, pterygoid process, and pterygopalatine foramen. Infiltration into the cancellous bone is another cause of risk residue, and inexperienced surgeon and early age of onset are the other risk factor for residual disease. So this is another treatment, radiotherapy. When radiotherapy is indicated, when it is unresectable, like in this radiology, we can see carotid 360-degree encasement of the carotid by the tumor, and patient was of very early age. It was less than 10 years of age. So blood volume was also less, and entire both carotids are engulfed within the tumor. So this comes as an unresectable tumor. When there's a persistent residue after the multiple surgeries, when the residual lesion lies close to the vital structure, where the surgery was very challenging, like around the optic nerve or around close to the carotid artery, and the dosage ranges from 30 to 35 Gray, with tumor control rate ranges from the 70 to 90. So this is one of the case report from the AIMS where radiotherapy was used as a tumor was very advanced stage and it was involving the carotid, and over a period of 3 years, it was completely regressed because effect of radiotherapy will generate relatively late, and effect comes relatively late. So it was roughly around 2 to 3 years, and literature is also supporting it's around 2 to 3 years it generally regress. But what are the complications with radiotherapy, like cataract, even pituitary hypopituitarism, temporal bone necrosis, and radiation-induced sarcoma can be seen. Like in this case, after 30 years of radiation, patient got sarcoma in the same region. Once it was declared as tumor-free, then after 30 years, he got sarcoma in this region. Next come the hormonal therapy. So tumor have estrogen, alpha, beta, androgen, and vascular endothelial growth factor. So initially diethylstilbestrol was used for hormonal therapy, but it has long list of side effects. Then comes a flutamide therapy. It has anti-androgenic effect. So it was used at AIMS in this study, and which is very much quoted in the literature. So here 10 milligram per kg per day was used for 6 weeks, and 7 to 44% regression was noticed, and primarily in the post-puberal group. So this is one of the radiology where we can see stage 2C JNA, and it was regressed to 2A. next comes the post-operative surveillance. So endoscope, once the surgery is done, because of the large volume of tumor, there may be scarring at different places. So endoscopic assessment, it is not a good tool for surveillance, because like here at 2 spots we can see some congestion, which can create the doubt that patient have tumor. So MRI is a best surveillance tool, as it has no radiation exposure, and literature is biased when to do MRI scan in post-op. Some suggest within the 3 days after the pacromal, and some suggest after 3 months. Here we are following 3 months, because when MRI is done at early stage, then the residue is generally very small. In such cases, it gives false impression. At 3 months of time, it generally enlarged to sufficient amount which can be picked up with the MRI. And Scott Brown says 5-year follow-up is needed to declare patient as disease-free. So this is one of the study from AIMS, where we prostate-specific membranous antigen was used under the guidance of Professor Alok Thakkar. It was found in the tumor as the JNA is vascular tumor, and this antigen is found primarily in the vascular tumor. So it was positive throughout during the study. And whenever there's a doubt with MRI, because of retained secretion, persistent edema, and hypertrophy of the mucosa, it can raise false impression. Like in this radiology, we can see there may be residue, but when PMSA was done in same case, it was not found. It was there was no uptake, so we declare patient as no disease at that present. But once the study was completed, we found one case where the patient came with a history of bleeding, and when we perform MRI, we could find there is some residual lesion, but it was negative on PMSA scan. So whenever patient came with symptom, it may possibly patient have disease, even though radiology may be negative in such cases. So close surveillance is required in such cases. Thank you.
Thank you, Hitesh, for a very illustrated presentation. Professor Khaja Nasruddin has also joined, so we can have comments from Dr. Khaja Nasruddin, followed by Dr. Bhargava, please. Is Dr. Khaja Nasruddin is online? Sir, are you available, sir? I think Dr. Khaja Nasruddin is not reachable. So we can have comments from the chairperson, Dr. Aditya Bhargava, please.
Yeah. No, Dr. Khaja Nasiruddin here. I'm Dr. Khaja Nasiruddin. Yeah.
Yes, sir. Please, your comments on the lecture, sir.
No, really, I am really very happy to see the different approaches for removal of angiofibroma by Dr. Hitesh Verma. Really, it is very fascinating to see all those things. And we in our Department of ENT and Head and Neck Surgery in HIMSR, we have been doing all these different approaches for the past 6 years or even 8 years, you can say, because it started during Dr. Sudhir Bahadur's time when he was heading the department here. And then after when I took over about 6 years ago, it continued. And it will be really nice if we have another workshop like this, or this one only, offline workshop at my department in my hospital at HIMSR. So I invite you, everybody, for that. Maybe probably the first week of April, if it is possible. Yeah. So I congratulate Dr. Hitesh Verma and all the members of the team of Department of ENT, Otolaryngology, Head and Neck Surgery from All India Institute of Medical Sciences, New Delhi, and I hope we can grow together and can do a lot of quality work which we have been doing. Thank you very much.
Thank you, sir, for your comments. Dr. Aditya Bhargava, please. Sir, your comments.
Congratulations to Dr. Hitesh for a very lucid and very explanatory, I must say, presentation. And the quality of the slides and the material present was very good. I have got a couple of questions from him. Can I ask? Couple
Yes,
of
sir.
queries are there.
Sir, we are running late, sir. Maybe we can have one question to Dr. Hitesh.
Okay. So my basic question, it's a very, very fundamental question that why we use femoral root for, this embolization. Why femoral root is used, such a long route from femoral artery going to the common carotid artery and all? Why not through neck? I mean, if this question can be, if some radiologist could have been there, interventional radiologist, but since nobody is there, nobody seems to be there, I am asking this question from Hitesh. Don't mind my lack of knowledge in this. This is a very, very cardinal, very, very fundamental question.
Yes, sir. Now there's a different kind of embolization technique is there. Can be super selective embolization, direct tumoral embolization also. So this was old technique, and even though we are following here at AIMS also transfemoral route, because it may be sometimes it may be difficult because internal jugular vein and other structures, vital structures are very close by here. But in transfemoral route, it is easy to access from transfemoral route as compared to the transcervical route.
Sir, can I add to that?
Yes, Ravi, please.
I think, sir, it depends on the person who is doing neurosurgeons and the cardiologists. Like in our center, we get embolization from the neurosurgeons as well as cardiac surgeons, cardiologists. So cardiologists, they are very much at ease when they are doing it through femoral route, because they are doing all the cardiac catheterization through femoral route. So they are well experienced in the femoral route, and that is why probably they are not using neck route. And I agree with Dr. Hitesh that the structures in the neck are very compactly packed, and they are important vital structures around the carotid. So it might not be very easy to cannulate a carotid in the neck.
I can, because whatever I have seen in various other hospitals, defense hospitals, where interventional radiologist is there, they prefer to go through the neck. And that's all. Over to Dr. Vipin for further proceedings, please.
Yeah, thank you, sir. Now we go ahead to the second part of the today's proceedings, which is a panel discussion on approaches to a patient with angiopharoma, and Dr. Ravi Meher is a moderator for this session. So I request Ravi to start the proceedings and introduce the panelists before we start the question answers. Over to Ravi.
Thank you, Dr. Vipin. At the outset, I would like to thank Delhi UI, especially Dr. Vipin and Dr. Taneja, for giving me this opportunity to moderate this session. It's a very, I would say, important session for our trainees and for our PG students. Can you see my screen?
No, sir.
Now you can see?
Yes, yeah, we can see.
So I think Dr. Hitesh has dealt the topic so exhaustively that there is nothing much to add in this panel. But nevertheless, I would like to ask few basic things from the esteemed panelist, and I would introduce my panelist. So Dr. Hitesh Verma is already there. He's from AIMS, New Delhi. He's an additional professor. of ENT, and he is an experienced endoscopic sinus surgery, and you can see that he has also written a book on rhinology. So he's a good rhinologist and an experienced endoscopic sinus surgery as well as angiofibroma surgeries. So I invite Dr. Hitesh Verma. Do we have Dr. Gautambir Singh? So Dr. Gautambir Singh is a director professor from Lady Hardinge Medical College. Do we have Dr. Gautambir Singh?
Can't see him.
You can't see. Anyway, so next is Dr. Rupa Mehta. Dr. Rupa Mehta is also professor from AIIMS Raipur, and we also have Dr. Sandeep Bansal, who is from PGI Chandigarh. So I welcome you all for this panel on angiofibroma.
Thank you, Dr. Ravi.
Yeah, Dr. Gautambir is there? No. So my first question, so we'll be having a few discussion on the presentation, diagnosis, and then the management. So when do you suspect angiofibroma? Like when the patient comes to you, when do you suspect that this patient could be having angiofibroma? Dr. Rupa Mehta, can you please answer this?
Yeah. Good evening. See, the patients, first of all, the age of the patient. The patients will be normally in prepubescent or pubescent age group. If the patient is a male from prepubescent age group with nasal obstruction, epistaxis, and nasal mass, like the picture you have shown. So then the section of angiofibroma is raised. So mostly these normally it is very well it correlates with the diagnosis of angiofibroma, and then the radiology helps in the diagnosis.
Okay, so Dr. Sandeep, you want to add something for, and any differential diagnosis you would like to keep, Dr. Sandeep, sir?
Yeah. Good evening, Dr. Ravi.
Yeah.
I think for angiofibroma, if it's clinically, if you want to say, the age, as Dr. Rupa just mentioned, and episodes of epistaxis and a globular fleshy mass in the nasal cavity, I would keep it as, and especially, and male, of course, male patient, I would keep it as angiofibroma only, and would confirm it with the radiological investigation, the imaging, the CECT as a first modality.
Dr. Hitesh, would you like to add something, like any differential diagnosis which comes to your mind while suspecting angiofibroma in a patient?
Sir, first is history, then examination. In examination, if we have single globular mass in particular area, and typical radiology which shows there's a contrast enhancing mass in the posterior part of the nasal cavity.
We will come to the radiology. I'm just asking about the clinical examination.
Yes, sir. If there is a maybe multiple polypoidal, it's not single, it may be multiple masses. In that case, we can consider some other diagnosis, because generally we saw single mass in the posterior part of the nasal cavity, and it is necrosis is less likely in the cases of mass, this JNA mass. So if necrosis is visible in the mass, for example, if there is a neck nodes with similar picture, patient came with neck nodes, in such cases it's maybe some other diagnosis. And there may be atypical presentation, like generally it doesn't extend into the maxillary sinus, but if it is extending into the maxillary sinus, then maybe something else we are dealing, and there may be erosion, direct vertical extension into the sphenoid, and like we can see from the if we are doing nasal endoscopy, it coming out through the cribriform plate area and it going towards the nasopharynx. In that case, it may be different.
Right. So
if you just can I add something, Dr.
Yes, sir.
Maybe if you just want it from a discussion point of view, and then maybe we can say episode of bleeding and infected enteroconal polyp as a clinical diagnosis without.
So that I wanted to listen, because
if infected enteroconal polyp, and if it's a younger patient, younger child, maybe even rhabdomyosarcoma can be kept as a diagnosis.
Right.
if it is a very young child. So just for the case of sake of discussion, I would.
So basically, any male child, young child, male sex in adolescent group, we must suspect angiofibroma if there is a history of bleeding, and all these patients must undergo nasal endoscopy. So with the advent of endoscopes, we are diagnosing angiofibroma at much earlier stage. Like I remember when when I joined my post graduation, we used to see large angiofibromas coming into cheek with typical frog faces. Those type of patients we are not seeing much today because of the advent of endoscopes, and all the patients who are having epistaxis with nasal obstruction, male patient, they must undergo nasal endoscopy. And regarding the differential diagnosis, because lots of postgraduate students and trainees are here in the webinar, I would say enteroconal polyp is definitely one of the differential diagnoses, and large adenoids also. I mean, I have personally seen and experienced that sometimes patients with enlarged adenoids are suspected, they are suspected to be cases of enlarged adenoids, and they are taken up for surgery. And intraoperatively, when you are curating or when you are try to remove the adenoids, you find that it is not adenoids, it is actually angiofibroma, right? So we must be very, very careful, because when you get an adenoid patient, you just get an X-ray done, right? And you are not getting any endoscopy or CT scan. So if you are making a diagnosis, you have to be very, very clear, and any suspicion, you must get a CT scan done, right? So that's my points. Now we come to the radiology. So what radiology, Dr. Sandeep, you want to get? I mean, routinely when the patient comes with angiofibroma, suspected diagnosis of angiofibroma, what radiology you would offer to the patient?
The first thing is a contrast enhanced CT scan.
Okay.
And if we see a vascular mass and suspicion of angiofibroma is confirmed along with the history, then we would go for a angiography.
Okay.
For two purposes, basically to know the feeders, and at the same time we can do embolization.
Right. Dr. Rupa, you want to add something?
First line of investigation remains the CT scan, and followed by once it is looks like the angiofibroma, then we have to, for surgical planning, we have to go ahead with DSA, CT angio, and if required, if there's intracranial extension, then MRI.
Right. So you would get a CT twice, first for diagnosis, CECT, and then you will go ahead for the second CT angio, or you want to go do it?
No, CECT and then straight away with DSA.
Okay, Dr. Hitesh?
Only in selected cases when there's confusion, do we need to get MR angio or some, but mainly it is CECT, DSA, which more than suffices, and only in revision cases or gross intracranial.
So in the first sitting only you will write CECT with angiography.
No, CECT first, then depending on the findings, and when we are planning surgery, then DSA with embolization, without depending on what are the findings. Okay. But initially, the CECT will suffice.
So your aim will be getting a CECT done and then taking the patient for angiography and embolization. Dr. Hitesh, what do you follow in aims?
Sir, if the disease is small, like from clinical look, like there is no proptosis and all that, in such cases, CECT is good enough.
Right.
But when the disease advances, so either patient may go for primarily open approach, maybe lateral or maybe anterior. So feeder is very important in such cases. CT angiography can be done at first stage, because if you know the feeder, good feeders come from the carotid circulation, and in that case you will go for pre-auricular subtemporal approach rather than doing with the maxillary swing. So in such cases, so you know your approach, which approach you will choose when the disease is advanced. So in that case, CT angiography is better because it is a non-invasive procedure which provides the feeder.
Right. So the approach might be different in different institution. What we follow is that whenever we have a strong clinical suspicion of angiofibroma, we'll get a CCT along with CT angio in the same sitting, because that will give you an idea about the feeder, what feeders it is getting, as well as it will help in the embolization part also, because the cardiologist or the neurosurgeon will be having some idea that I am going to have this feeder from the ECA, and it is not the ICA which is supplying the tumor, right? So that helps in embolization also, right? But if you are not having a strong suspicion, you can get a CT scan, CCT in the first sitting. Indications for MRI. So these are the points in the CT scan which we must see for confirming the diagnosis of the angiofibroma. All the postgraduate students are very commonly asked about the CT scan findings of the angiofibroma, and one of the important signs is the Holman-Miller sign. Though it is seen in angiofibroma, it is not a pathognomic sign for angiofibroma. Any tumor which is occupying the infratemporal fossa can show Holman-Miller sign, but it is the important thing is that there is erosion of the base of the pterygoid and the erosion of the floor of the sphenoid sinus, plus the widening of the Vidian canal, which actually clinches the diagnosis of angiofibroma. Okay, so CCT is for initial workup, MRI in case there is an involvement of the carotids or there is an intracranial extension. Right? So we come to the embolization. So when and how? I mean, when will you do the embolization and how will you do, and what is being followed in your institution? So I would like to have comments from Dr. Sandeep, sir.
In our institute, the interventional radiology, neuroradiologists do all the angiographies and embolizations.
And what materials are they use?
It depends upon the patient's affordability also. Coils are very expensive. If patient is affording, then they use the coils. Otherwise, they use PVA or maybe
any specific reason why are you using coil? I mean, will you prefer a coil than a PVA particle?
No, not me. See, this.
Sorry, sir, please unmute yourself. Yes, sir.
This decision is usually taken by the intervention radiologist only.
Okay.
We usually we are planning our surgeries that we operate within 24 to 48 hours. So for us, from the surgeon's point of view, even gel form is good enough.
Right. Okay, Dr. Rupa, would you like to add something?
Yeah, at our institute also, interventional radiologists carry out the procedure using PVA particles mostly, like for most of the cases. In fact, for all the cases, they use PVA particles. And we carry out surgery within 48 to 72 hours of embolization.
Right. Dr. Hitesh? Yes, sir.
No, let Dr. Hitesh finish. I would just like to add something.
Sir, here also intervention radiologist is doing that. And they are using PVA particle and gel form depending on the patient affordability also.
Okay.
So when we are using biological material, then chances of surrounding inflammation can be there, like with gel forms and all that.
Yeah.
But when we are using non-biological material, then surrounding inflammation is less. And I feel surgery is done, if surgery is done on same day when the embolization was done, bleeding is much less as compared to done on second or third day.
Okay.
So I just wanted to add to this only. It is because of the practical issues and feasibility issues that we get the embolizations done a day before. Otherwise, as Hitesh just mentioned, it is the best if we do it the same day. Like I had recently operated a patient, not recently, but a few months back, 3A Redkowski 3A tumor. And the patient was taken up for angiography and it had to be abandoned because the child used to be sleeping in the sitting position only.
Okay.
Because of the mass was so big in the nasopharynx that he would choke and he could not lie down supine. So we had to abandon the procedure, and it was decided that on the same day of the surgery, like we intubated the anesthetist intubated the patient in the radiology suite, and from there the embolization was done, and intubated patient was shifted to our OR, and we operated it at the same time,
Right, sir. So, would you like to embolize in primary tumor or a recurrent tumor? Like, what is your take on in recurrent tumor? Suppose there's a recurrence and then the patient needs another surgical intervention. Would you like to embolize this?
You're talking about recurrent or primary tumor? I get
Primary,
all my
obviously,
patients.
you will do an embolization.
Yes. In recurrent tumors also, if it's a small tumor, then I do not. But if it is like a patient operated outside and say large recurrence, then I would still go for embolization. I'm doing all my angiofibromas endoscopically, so I do get my patients.
Okay. Dr. Rupa, would like to add something?
Yeah. Recurrent tumors are more, like prone to have more weird and more, different supplies, because the primary surgery has already been ligated or embolized. So they might have more feeders, aberrant feeders from other arteries, from IC, etc. So depending on the DSA findings, if the radiologists are comfortable with going ahead with DSA, with embolization, then they go ahead. Otherwise, at times we have to differ from the same.
Of course.
Right. Absolutely correct. So, I mean, in recurrent tumors, because during the primary surgery, already the maxillary artery and the spinopalatine artery has been ligated or cauterized or coagulated. So the recurrent tumor might be having blood supplies from the ICA, and it might be sometimes risky to embolize these tumors, because there is very high chances of particles going to the internal carotid system, leading to hemiplegia and blindness, right? So we had a few complications like this, and that that has warned us to not to embolize recurrent tumors until unless they are having supplies from external carotid artery. So that is important. So
Dr. Ravi, that is definitely there. Now that we will come to know with our angiography.
With angiography, yes. So DSA will help in this condition, definitely.
Yes. So if it is not from the internal, then only we go ahead. That is obviously there.
So in our institution, there is some slight difference, because we don't have interventional radiologists. Our embolization are being done by neurosurgeons and by the cardiologist. So the neurosurgeons, they use the PVA particles. They are more experienced with the PVA particles and gel foam, and the cardiologists, they are using microcoils. So this was one case, like this was a very small tumor and limited to nasopharynx, a very small extension to the pterygopalatine fossa. And this patient was embolized. And when we removed the tumor, you can see the coil actually came out from the internal maxillary artery. So in fact, what happened, the patient, when the tumor came out, the patient started bleeding on table, and we had to cauterize the bipolar with the bipolar cortice. So this can actually happen. And this is one of the things which can happen with when you are embolizing with the coil, right? So otherwise, it is important that the embolization is done by some experienced person, because there are chances of definitive chances of particles going into the internal carotid system. So super selective embolization is the the management of choice in these cases, and it must be done by an experienced surgeon. We had some cases of TIAs, like patient having hemiplegia and hemiparesis, and obviously this patient improved after 24 hours with the management, but this can actually happen as one of the complications of embolization. So we come to the classification. This was a nice article which has actually mentioned all the classification of the angiofibromas, right from our from Indian subcontinent also, we have lots of work on angiofibroma, and Dr. Sandeep must be knowing about Mann and Mehra classification, which was from PGI Chandigarh. And though this classification was based on the extent of tumor and the what surgical approach you would take to remove the tumors, but with the advent of endoscopes, I think this classification does not hold much importance today. So the classification which has been already told by Dr. Hitesh is the Radkowski's classification, which is the most commonly followed classification. And there has been one classification by the University of Pittsburgh. So can somebody tell me about this classification? Dr. Hitesh, University of Pittsburgh Medical.
Yes, sir. It is based on embolization.
Right.
So how much tumor vascularity left after the embolization is based on that.
So this is a classification which was actually advocated by University of Pittsburgh Medical Center, and what they do, they embolize all the tumors. They will embolize, and they will then see what tumors are having residual supply from internal carotid artery. So if there's an internal carotid artery residual supply, that means that it is stage 4. Directly, it is a stage 4 tumor. And if there's an associated intracranial extension, it is stage 5. So this is a good classification if you are actually dealing all the angiofibromas by endoscopic approach, and whether to prognosticate. This is for a good prognosis. Suppose it's a stage 4 tumor, that means it has a poor prognosis, and it's a stage 5, even poorer prognosis. So this was a classification, although I mean, we are not doing all the embolization, but this can be done in cases where you are doing embolization.
Yeah, basically this Snyderman's classification tells us about,
it was given by Snyderman's.
Snyderman, yeah. So it gives us the chances of recurrence of the tumor.
Right, prognosis and recurrence.
According to the residual vascularity after the embolization.
Right.
So the stage 4 and stage 5 would have residual vascularity, blush, tumor blush.
Right. Absolutely correct. So this helps in prognosis as well as chances of recurrence. So pre-treatment, Dr. Hitesh has already told about the pre-treatment. Do you offer some pre-treatment therapy for the patients of angiofibroma?
I'm fine, sir.
Dr.
Not at our institute. So not at our institute. We normally don't offer any medical management or just a course of antibiotics beforehand, because at times they have obstruction and features of sinusitis. So a course of antibiotics.
Dr. Sandeep, sir.
So we don't give any pre-treatment except very a few cases a few years back, based on Professor Alok Thakkar's one thesis about hormonal therapy on large intracranial tumors to decrease the tumor mass. We had tried, but otherwise we do not give any pre-treatment medications.
Okay. Dr. Hitesh, what do you follow at AIMS?
Sir, we are giving this medication. It helps in some amount of bleeding can be controlled. Sometimes tumor regression can be occur. So patient generally feel more comfortable when we start this treatment. But a variable outcome can be there, and not all patients have some improvement.
Any particular subset of patient you would like to give pre-treatment, or?
According to the study, it was more found in post-pubertal group, but there was few cases in pre-pubertal also. So we are giving both the groups. As we have long waiting, so sometimes patients also engage with this medication. They got something.
Okay.
But limited side effects are there, sir, that are reversible with this. So we have not seen any permanent side effect with this medication.
Okay. Can I request Dr. Khaja Nasruddin to please switch off his mic? Thank you, sir. We are not following any pre-treatment. In fact, when I was going through the literature, I found the article from AIMS, and I mean, as Dr. Hitesh has told us, I think in post-pubertal group patients, we can definitely try flutamide, and there has been, there's a good amount of data available on efficacy of this flutamide in pre-treatment of angiofibroma. Earlier, people have used diethylstilbestrol, but again, diethylstilbestrol has lots of problems because it causes feminization, right? So loss of libido and feminization is one of the complication of diethylstilbestrol, and that is why it is not being used. So flutamide is a non-steroidal androgen antagonist. A 6-week treatment in the dose of 10 milligram per kg body weight can be tried, and it is generally ineffective in pre-pubertal patients. So post-pubertal patients who are having high levels of testosterone are good candidates. So now we come to the approaches. So we have seen Dr. Hitesh talk, and we have seen very nice videos about all the approaches. I would like to ask my panelists what approach to be preferred in what stage, right? So how do you decide? So the question is, how do you decide a surgical approach for angiofibroma? So Dr. Bansal, you can give your comments.
We started, like I started with the transmaxillary approach, of course, as we all must have. But last a decade or so, 8 to 10 years, I am doing exclusively only endoscopic approaches.
Okay, right, sir. Dr. Rupa, so you are, Dr. Sandeep, you are doing for all the stage, like even tumors going into the intracranial cavity, engaging the carotids.
For till 3A, I'm doing endoscopic approaches,
Okay.
and 3A onwards, maybe with our neurosurgical colleagues.
Okay. Dr. Rupa?
Sir, at our institute, mostly till 2B, we are very comfortable with doing with endoscopic. But when it comes to 2C and 3A, we like exercise like individual, depending on the patient. We at times, like most of the times, in fact, for 2C, 3A, we go ahead with the open approaches, transmaxillary approaches. Okay. And for 2C, 3A and above types.
Dr. Hitesh, what is your experience?
Yes, sir. Endoscopic approaches is up to 2B or even 2C. I've shown few videos on 2C. So that is a good enough. But everywhere they are discussing about the stage and approach. Tumor volume, blood volume in the patient is very important. If you are transfusing too much blood when we are doing endoscopic approach, there are chances of too much blood loss. In that case, we may lose a patient. So when the bulky lesion with less blood volume, we generally prefer open approach because it is relatively easy.
So right, absolutely right. So
when there is a gross or intracranial blood supply, 40 to 50% from ICA, in that case, it's open.
See,
yes, sir.
The endoscopy, like we can always go ahead with the endoscopic approach. It can be converted to an open approach anytime, like if we feel. But I think when we are doing a 2-surgeon 400 technique, modified endoscopic Denkers, along with posterior septotomy, and we can cut the tumor into 2 halves if needed, if they are very bulky. We are able to tackle most of the tumors. Usually, if not a problem.
Okay, sir. Sir, I think endoscopic approach is a good approach because it has a less morbidity to the patient, but it also depends on the experience of the surgeon and the equipment available.
Yeah, definitely. There is
that is the most important thing. I mean, according to me, if the surgeon is not very much experienced, he should start endoscopic with tumors limited to nasopharynx and sphenoid. So midline tumors, you start with the easy cases first, and later on graduate to more difficult cases. Right?
That's how we have all learned, actually.
Yes, that's how we have learned. When I joined as a PG, like endoscopes were just coming in the field of ENT. They were just like invented for functional endoscopic sinus surgery, and we used to do all approaches, all open approaches. I've seen transpalatal, transmaxillary, facial translocation, maxillary swing, all these open approaches we were doing. But as we started gaining experience, we started doing endoscopic. Initially, tumors limited to the nasopharynx, stage 1, then stage 2, and probably stage 3 also. But again, it depends on the experience of the surgeon and the equipment available. There's no heroism I mean, to
absolutely
start with a class 3 tumor, stage 3 tumors initially without any experience of a smaller tumors. So that is my advice to the youngsters and to my residents. Sir.
And there, yes, and absolutely, and there should not be any ego in converting an endoscopic approach.
Definitely.
Endoscopic to an open approach anytime.
Definitely,
anytime.
Sir. If you are stuck, definitely there's no ego. There should not be any ego issue. You should immediately convert the into an open approach and try to remove the tumor.
Absolutely.
So I would just like to tell our residents and the trainees about because nowadays more and more endoscopic approaches are being done. The experience of an open approach is limited to our residents. They are getting less and less exposure to the Weber-Ferguson incision. In fact, 2 weeks back, we did an angiofibroma and we got stuck endoscopically. We had to convert it in open surgery. And I asked the resident, have you seen a Weber-Ferguson? And he said, I have not seen a Weber-Ferguson approach. So,
but I think this COVID has been kind to let the resident have a feel of all open approaches
yes,
during
but
maxillectomy,
right,
subtotal
but
maxillectomy.
yeah, we did most of them endoscopically, but definitely yes, COVID has given more experience. So transmaxillary approach and then mid-facial degloving approach, which was like to avoid a facial scar, and then facial translocation, right? So these three approaches are very good approach, very good versatile open approach to remove any extension of an angiofibroma. So whatever extensions are there can be tackled with these three approaches. So what are the indications of endoscopic resections? And I mean, for an experienced surgeon, any tumor can be is amenable to endoscopic surgery, but for a routine surgeon, routine endoscopic ear surgeon, endoscopic sinus surgeons, tumor which are limited to nasopharynx, nasal cavity, and pterygopolant fossa, they are good to be tackled with endoscope. Minimal extension into infratemporal fossa, posterior tumors posterior to pterygoid plates, and extension to the orbit and the paraseptum. So mostly the midline lesions are easily accessible to endoscopic approach. So now I come to important points about the endoscopic. What are the tips you would like to give to our youngsters for endoscopic approach? Sir, what tips would you like to give?
I think the first and foremost is do not touch the tumor till you have, made it free from all the surroundings.
Absolutely
Once
correct, sir.
you have taken care of all the adhesions, and then it's.
So that is I think that is the golden words about endoscopic approach you have told. Never touch the tumor until you have freed all the extensions. Very nice.
Yeah. And as Hitesh was using a co-blator, it's a great tool, which has made our job of the endoscopic surgeons much more easier.
Absolutely.
And when you are planning an endoscopic approach, do not hesitate. I think right from the word go, so anything beyond 2B, just do a posterior septotomy, do a modified Dankers, and approach the tumor head on from all sides so that you can take care of all the adhesions. When you have done that, I don't think so you will face any difficulty in removing the tumor.
Dr. Rupa, would you like to add something?
Even in endoscopic approaches, wide exposure is very, very critical. And the pre-operative, radiological evaluation and planning is very, very important when you are planning endoscopic approach, because there are multiple lobulations in various places. So depending on those, might have to, like Dr. Hitesh also showed, there's posterior sublabial and sublabial windows to be made at times when there is infratemporal fossa involvement, and we're trying to remove it endoscopically. And it has been published by Dr. Bradu also, a 4-port approach. So all these things have to be planned very nicely beforehand. Okay, but depending on the lobulations, the extent, we might have to take accessory steps and try to mobilize the tumor to deliver it. That is very, very important. And yes, very good anatomy and hemostasis. Anatomical knowledge and hemostasis is again very important, because once the field becomes bloody, it is very difficult.
Absolutely correct. Very good points from Dr. Rupa. Dr. Hitesh would like to add something.
Sir, additional instruments which are required to control the bleeder should be available and should be checked before the planning the surgery during the operation. And in borderline cases like 2B and 2C, which can convert endoscopic or open, radiology should be done in closer interval. Otherwise, there may be chances if we are doing with old radiology, in such cases, maybe tumor can extend. Once it's 2B or 2C, it extend far more as compared to an early stage.
Absolutely correct.
Risk of conversion to open is high.
Right. So very good points from all the panelists. So
I think another thing to take care of the recurrence is that we should definitely drill the Vidian canal, and the pterygoids.
Right. So that is also very, very important to prevent recurrence of the tumor, because many times the tumor is actually infiltrating in the Vidian canal bone and the surrounding area. So cancellous bone is infiltrated with the tumor cells, and drilling them actually prevents recurrence. Right. Absolutely correct. So I think as far as endoscopic tumor excision is concerned, we must have a very good study of the radiology to know what are the possible extension of the tumor, right? That is very, very important. And then you must plan mentally how you're going to remove all those extensions, right? So there's a good amount of infratemporal extension. I think the supply is coming from the lateral part, and it is going into the tumor. So you have to control the lateral part of the tumor by doing an endoscopic Denkers and removing the posterior wall of the maxilla, and then controlling the maxillary artery and the sphenopalatine artery. So that is very, very important approach. And plus, it should be centripetal dissection from lateral to medial side. So you have to do dissection all around the tumor and go into the tumor in the last, once you have released all the extensions, right? Drilling, sir has already told you, do not touch the tumor. That is the golden words. I would say, do not touch the tumor until unless you have tackled the blood supply of the tumor. You have to clip the maxillary artery and the sphenopalatine artery, which is supplying the bulk of the tumor. External pressure into the cheek and the infratemporal fossa behind the angle of mandible can actually push the lateral part of the tumor more medially and can help in removing of the tumor, right? And sphenoid sinus wall you have to remove. And finally, dissecting the tumor. The tumor is relatively loose at the lateral part, but it is very much adherent to the pterygoid plates and pterygoid base as well as the Witten canal. So that is the area where you would like to have a sharp dissection, and you might use a coagulator or a drill to remove the tumor. So, so indications of open approach: very large tumors, broad base, skull base infiltration, extensive supply from internal carotid artery, encasements of internal carotid artery, vein infiltration, which is very, very rare. Most of the tumor is actually extradural, and if there's a residual or recurrence tumor. So that is the. So what would like to do a tumor for a patient who has a tumor like this? Dr. Sandeep, sir. So this is a patient who presented to us with a huge tumor. This tumor was actually going into each and every space, right? And you can see that there is a bulge in the temporal region. So it was going below the zygoma, and it was actually going into the temporal region, right? So here was a temporal extension below the zygoma. So what would like to do for this patient?
Pray to God.
Pray to God.
No, on a serious note, I think like there is no other way out except doing a
open approach.
Approach.
So there are some limitations.
This is beyond any classification staging.
Yes, sir. So I would say that there are certain patients who would definitely require an open approach. You would not be able to do the endoscopic approach. This tumor was actually going to the parapharynx also, right? So temporal region, infratemporal fossa, cheek, and so this patient when
he will require some lateral skull base approach along.
So it was actually this patient was lucky by that it was not going lateral to the carotid; it was all medial to the carotid. And when this patient came to me, I did not have this idea that I am dealing with an angiofibroma. I felt it was a soft type of tumor, and I thought it is a massive lymphangioma. But we got a CT scan done, and then we found that it is not a lymphangioma; it is actually a angiofibroma. And we excised this tumor, and this came out to be a angiofibroma, which was whatever I have searched in the literature, it was the largest angiofibroma reported, 750 grams of tumor. So this was almost 21 centimeter by almost 20 centimeter large tumor, which we excised, and this is the post-operative picture of the patient. So he had some deviation of the zygomatic process because of the constant pressure of the tumor. But his cosmetic appearance improved drastically after the surgery.
Great job done.
I don't know okay. So so this is the tumor which has an intracanal extension. There is a cavernous sinus involvement, and you can see here in the scan there is a internal carotid artery encasement, right? So this is the tumor, and this is a CT scan of the same patient. And you can see the tumor is actually going into the sphenoid, and there is a medial extension into the intracanal part of the cavernous sinus, and the tumor is actually going medial to the carotid, right? So what do you think? How will you approach this patient, sir?
See, one is like we can do a stage surgery, especially when the tumor is going medial to the carotids.
Right.
We can remove the whole of the tumor except that small intracranial part, and then maybe tackle it. We can just remove that all the extracranial part and maybe tackle the intracranial part by some gamma knife or something. Also, we can think of that and discuss with the
good
patient.
option. That's an option. Dr. Rupa,
Yeah, but I think it will be with the discussion with the patient only.
Right.
The morbidity has to be seen for intracranial, or with your neurosurgical team, we can do a subcranial approach and open it from the.
Okay, Dr. Rupa, would you like to comment on this?
So we would like to get an MR angio and along with and a neurosurgical opinion, and along with them, open approach might be tried.
Okay.
And if there might be some residual, there are high chances of some residual around the carotid being left. Right. That can be, like waitful watching or some ancillary procedure treatment like Sir said, gamma knife or all. But otherwise, we can even wait and watch. Waitful watching can also be tried. Around the IC, at times we have to leave some amount of tumor around the vital structures.
Absolutely correct, right. Dr. Hitesh?
So these three films are of same patient?
These are a picture of same patient. They are same. You can see can you see the names? 13 year. So these are scans of same patients.
So if disease is medial to the carotid and eroding the lateral or the sphenoid sinus, and CT angio or even DSA is suggestive there is no vascular supply from internal carotid artery, then this is less likely it's infiltrated into the carotid region. In that case, we can remove endoscopically also.
Absolutely
and
correct.
If it is tumor is lateral to the carotid and even posterior to the carotid, and in that case, lateral pre-auricular subtemporal approach is better, because lateral access is relatively difficult from the even maxillary swing approach, because maxillary swing approach provide infratemporal fossa, good approach to the infratemporal fossa, pterygomaxillary, and deep to the pterygoid, but it's relatively limited for that.
Right. So this tumor actually we tackled by open approach with endoscope assistance. Right. So we did an endoscopic assisted open approach, and we were able to remove the tumor completely of the carotid. But only problem was that the patient started bleeding from the cavernous sinus, and it was a very, very brisk bleeding from the cavernous venous bleed coming from the cavernous sinus, and which we tackled by the Surgicel and packing. The patient was operated just in the last OT, so I don't have the videos. It is yet to be edited, but this patient we tackled by open approach using endoscope assistance.
Dr. Ravi, whenever we open the cavernous sinus, there is bound to be a bout of bleeding which settles down. And flow seal is a very good tool in our armamentarium.
Unfortunately, sir, we did not have flow seal in the OT on that particular day, and we were actually we stopped this by using a good amount of fibrillar Surgicel.
Fibrillar, so okay, fine. That also
Surgicel, and we could then manage the patient. So we are yet to.
You can always try a fibrillar into Surgicel and then packing it. It helps.
Yes,
it is much more effective.
Right, sir. So we are yet to get a post-op CT scan or MRI, but we are hopeful that we have removed the complete tumor.
Sir, if a long segment of carotid artery is encircled, in that case, radiotherapy is much better. If narrow segment is involved,
yes,
then we can go.
Try.
Absolutely. I fully agree to Dr. Hitesh. So you must have a very good study of the MRI scans in these patients, and MRI is very important. It's a vital investigation if you are suspecting an intracranial extension. So that will tell you about the involvement of the carotid, long segment carotid involvement, complete 360-degree encasement. I mean, this is going to be a difficult even by the open approach, and you might have to give a radiotherapy to the patient.
So in that case, one more, sir, cross circulation should be checked before.
Yes.
Otherwise, so if you are handling and you need ligation, in that case, neck control over the internal carotid artery should be there.
Right, but I mean, if there's internal carotid artery bleeding, I mean, there will be, you cannot control by one side. like, so you have
sir, obviously in that case, if you go with intracranial, you will go with craniotomy. So in that
yes.
case, you can access and you can take control over the carotid above to that.
Okay.
Hi, Ravi. We are having,
yes, sir.
Ravi, we are having very interesting discussion, but we have to draw a line. Maybe
I will just wind off in next 5 minutes.
Yeah, thank you so much.
Okay, thank you. So just quickly tell about the intracranial extension tumors, which are, so Dr. Hitesh has already told us about the lateral approaches. So if there's a tumor which is lateral to the carotid and the cavernous, you have to go by a lateral skull base approach, and tumor medial to the carotid can be tackled with open approach, transmedullary. So bleeding, Dr. Sandeep has already talked about the use of Surgicel and the Flow-Seal. Flow-Seal is a very good help in case of extensive bleed, even like in cases of pterygoid plexus bleed, or in cases of bleeding in the infratemporal fossa where you cannot find out the bleeder. So Flow-Seal can be really life-saving in certain conditions. So if you have the product in your OT, it must be used, right? Endoscopic assisted and facilitative. So again, in cases of ICA bleed, you have to have a good neurosurgical suite setup or a cath lab where you can actually do a stenting or coiling, right? So how will you prevent recurrence? So this is almost coming to the end of the panel discussion, sir. Dr. Rupa, would you like to comment on prevention of recurrence?
Yeah, first is drilling of the pterygoid wedge, because there is that is the most common site where the tumor remnant is residual is left. So drilling of the pterygoid wedge and including the median canal. So that is one this thing. Second is again the preoperative. We have to see all the lobulations, all the extensions, and that needs to be tackled. With all those lobulations and extensions have to be removed, and wide surgical exposure.
Absolutely correct. So you need to have a good surgical exposure, control all the vascular feeders, and remove all the parts of tumor, and including drilling of the Witten canal. So post-op surveillance, Dr. Hitesh, you have already covered this in the topic, and can you just summarize the post-op surveillance? How will you do, and what are you following in your institution?
Sir, post-operative, we generally do MRI at 3-month interval. If MRI is doubtful, there may be lesion. In that case, we go ahead with PMSA scan. This is prostate specific, because sometimes there may be persistent edema, scarring, and can lead to some enhancement especially in the pterygoid base region. So this may give false implication that there may be residue. So it's better. Endoscopy is not a good tool because it's run under the periosteum and under the mucosa. So it's very difficult to identify with the endoscopy unless we have good cavity, because general tumor is very large. So scarring is more. In that case, it's very difficult to assess. MRI is a better tool for assessment.
So very good points by Dr. Hitesh. So I just want to know if this PMSA scan is available routinely in metro cities, or it is a part of the study only at AIIMS?
No, sir, it's routinely, we are doing routinely.
I mean, it is like available in other MRI centers in Delhi, like.
No, it must be with some nuclear and medicine.
It's done in the nuclear medicine department.
Nuclear medicine department.
Nuclear medicine department. So, do we have this facility at PGI Chandigarh, sir?
Yes.
PMSA scan.
Yeah.
Okay. So maybe if we have some doubts, we can send the patient to Dr. Hitesh for PMSA scan from Maulana Azad.
Most welcome.
Right. So I think PMSA scan is a good modality which is coming up in differentiating a recurrence tumor from fibrosis. So management of recurrence. Anybody can attempt, sir? Anybody? Dr. Sandeep, Dr. Rupa?
I would still again go for endoscopic approach only first. So
I wanted to tell our listeners that most of the recurrence are actually not recurrence. It is actually residual tumor.
Residual disease.
So the residual tumor has actually grown again, and so to prevent recurrence, the first and foremost is to drill the Witten canal. That is the most important part. And generally, with increasing age, the tumor, if there is a small recurrence and you can follow the patient, if it is not progressing, then you can just leave the patient like that. You don't have to go again and reoperate until unless the tumor is progressive and the tumor is progressively enlarging. That is why only when you have to tackle the recurrence. Otherwise, you can just wait and watch. It's very small tumor, small enhancement can be followed up. Right? So, in the end, I would like to tell all the residents that this is a very nice article from AIMS by Professor Alok Thakkar, and this is a review article on nasopharyngeal angiofibroma, and I must say that all the residents must read this article. It's a very, very important and very beautifully written article, and it tackles everything, whatever Dr. Hitesh has told and whatever we have discussed in this panel discussion, you will find it in this article. So my sincere request to all the residents and trainees to go, please read this article. It is available free online. And if you have any problem in accessing this article, you can WhatsApp me. I will send you the article. So in the end, I would like to thank all the panelists, Dr. Hitesh, Dr. Sandeep, and Dr. Rupa for their excellent inputs during the panel discussion. And I'm sure this would definitely help our viewers in, making them more experienced while tackling the angiofibroma. Thank you very much.
Thank you so much, sir. Thank you so much, sir.
Thank you, Dr. Ravi. Thank you, Dr. Vipin, so much for inviting me for this panel discussion today.
Thank you, sir.
Thank you, Ravi, and all the panelists.
One more thing, Dr. Vipin, I'm sorry, I am interrupting you. I just want to share this last slide. Can you see this slide?
Yeah, we can see it.
So I invite all the members of Delhi OI to this seminar which we are having on 3rd of March from 2 p.m. to 4 p.m. On 3rd March at Maulana Azad Medical College, ground floor lecture theatre. And this seminar will be on teleotology and universal hearing screening. And it is organized by Department of ENT and PSM of Maulana Azad Medical College and the State Program Officer of National Program for Prevention and Control of Deafness. So please be there and participate in this activity. We are also having poster and slogan writing competition, and exciting prizes are there to win. And this program will be followed by high tea. So I invite all the members to please join. Thank you very much.
Yeah. Thank you, Ravi, for a wonderful moderation. And I thank all the panelists, Dr. Sandeep Bansal, Dr. Rupa Mehta, of course, Dr. Hitesh Verma, for joining this session and bringing out wonderful contentious points, which are very useful for day-to-day practice. Thank you so much. I have a couple of announcements to make. On 16th of March, we are having a 2-lecture series on approaches to infratemporal fossa. So this lecture will be delivered by Professor Ziv Gill, who is at Israel Technion University, Haifa. And we have divided the lecture into 2 parts. So first part of this series will be on 19th of March. And the second part will be a week later, the subsequent Saturday on 26th of March. Infratemporal fossa is a difficult topic. So, and Professor Ziv Gill is a master. He has written a book on approaches to infratemporal fossa and several other books also. So I invite all of you to participate in this, and we can learn from each other, and you can ask questions to Professor Ziv Gill. And on 26th, we'll be having another lecture by Professor Patmesh Pai on T4B oral cancer, the compartmental section of on T4B oral cavity cancers. So these 2 will be on 26th. And as far as the membership is concerned, I invite all the non-members who are eligible to become member of AOI to be part of AOI. This is a very vibrant community. We focus on academics, and we can contribute to your academic career and your surgical training. And so I invite you to be part of AOI Delhi. And with these remarks, we can close the session. And I thank all of you for joining. Thank you very much.
Thank you, sir.
Thank you.
Thank you.
Thank you. Good evening.
So, shall I stop the YouTube
Yeah,
live
please.
streaming?
Yeah, sure, Rahul.
Okay,
Thank you,
thank you,
Rahul.
sir.
Thank you.
Welcome, sir.